Can I just get a wave from some of the sites if you can hear us down in Vancouver here and see that there's a presentation on the screen, either a wave or a thumbs up? Everyone's good? Awesome. Okay. So welcome again, everyone, to BCEHS and UBC Medicine Paramedic Round. I'm Dr. Sandra Jennison, one of the regional medical directors. Today we've got a mishmash of presentations. We've got three, actually. We've got one on cardiac arrest, one on the palliative clinical pathway, and then one on a project by one of our paramedic and medical students. He's going to tell you about a project that he did. Just a quick reminder, everyone, to please ensure that your mics are muted. Certainly if you have a question, unmute your mic and ask, but for the background, just leave it off. We'll get started. So I'll let you guys introduce yourselves and go from here.
Thank you, Sandra. My name is Jennie Helmer. I'm a paramedic practice leader and the research lead for BCEHS.
My name is Leon Barnowski. I'm a paramedic practice leader for BCEHS.
And we are going to present to you today the Assess-See Treat and Refer Palliative Clinical Pathway, which is the first pathway that's been designed around Assess-See Treat and Refer. And as we present, I hope we can answer some questions as we go. So what we'll do is at the end, we'll answer any questions that you might have. So this project started a year and a half ago with funding from CFHI and CPAC. So those are two national organizations that receive funding from Health Canada. And we were one of 7 agencies across Canada that received this funding with the objective being to create a paramedic approach to managing palliative emergencies who are calling 911. So a relatively novel concept, and although we've been doing these calls for a long time, we didn't necessarily have a standard approach. So that is the objective in its entirety of this project. We also entered into an agreement with the BC Centre for Palliative Care where they were our co-sponsors. So the project itself would not have been possible without CFHI and CPAC, and I think that that's a really key piece to understand as they were the main funders. Over the last year and a half, we've spent a significant amount of time working with each of the organizations that you see on the screen here, in some ways to explain who we are as BCEHS and what we do and who best to communicate with from each of these organizations, since palliative care, when patients are calling from an emergency perspective, transcends each of these groups. So those are all the groups that have been very heavily involved in consultation to get to where we are today. So let's talk a little bit about who we are. I think everybody watching knows who we are, but I find it helpful just to bring everyone back to some of the data. So BCEHS as an organization is responding to close to 700,000 calls a year between all of our pieces of paramedic administration. So that is a call a minute. We're obviously very busy between 3 dispatch centers spread throughout the province, a little over 4,000 paramedics, dispatchers, and call takers, and 185 ambulance stations. So when we meet with these other organizations that may not know us as well, that is one of our big early messages, is truly to share who we are, that we are the sole pre-hospital care provider in BC, and also to explain what we do. And that's been a big part of the conversations to date. When the project first began, we didn't actually know how many palliative emergencies we were managing in a year. So we spent a considerable amount of time data mining to truly understand what these numbers are. And what we discovered through our own data and matching that to CIHI data, which is hospital outcome data, we understood that in 2016-17 we transported over 2,500 palliative patients that had contacted 911, and we took those patients directly to ED. Now, as an organization, since 1974, that's what we've done. We've transported patients to emergency departments because that's been our mandate. So when we present this, it's really helpful to understand that that's where we come from, and that's why primarily we've transported these patients to ED. Now, unfortunately, once these patients arrive in hospital or en route, or as we're rolling them through the doors of the emerge, or as we transfer them over to the triage bay, they are dying. So we understand that of those over 2,500 patients, 63% of them are dying before admittance. Now, national and international research is telling us that the majority of palliative end-of-life patients would prefer to die in their home or community. And we're not just talking about death, although traditionally that's when they tend to call 911, is at that very, very acute stage. We also understand that the trajectory includes simply acute crises. And at the same time, those patients, generally speaking, if possible, would prefer to be treated at home and not transported. So the gap that we're looking to fill is which percentage of these patients can we truly treat at home appropriately? Can we symptom manage? There will always be patients that we cannot manage at home and we will have to carry on transporting them. But this is what we'll look to decrease, is that we don't want to have 63% of the patients that were transported that are known palliative to die in hospital before being admitted. I'm going to hand it over to Leon.
Morning, everyone. So we've identified a gap in practice. We've identified an area in the organization which we want to make improvements to. So how are we going to do that? And basically the way that we build on making these improvements is to use the 4 pillars of advancing practice. So these are 4 pillars that you need within an organization to support any advance or change in practice. And that's good clinical leadership, facilitated learning, evidence, and a need within clinical practice. And so that's a theme that within our department in clinical medical programs with the medical directors and in partnership with operations, that we as practice leaders work to develop and bring forward new initiatives. And so that's the way that this presentation has been broken down. How are we going to hit each one of those 4 pillars to advance this new practice of leaving patients in their own home, collaborating with care teams, respecting their wishes to have a peaceful death or remain comfortable with community care teams. So phase 1 was to look at how the calls come into our dispatch centres. So that was looking at how often 911 calls are coming in from palliative patients, looking at what palliative education the organisation currently has and what the needs are, any updates to clinical practice guidelines, and within our licenses, what scope expansions and endorsements are needed legally to ensure that we can deliver that care operationally. That's right, slide. Sorry. So palliative inclusion criteria. So we're looking at patients that have been diagnosed with an advanced life-limiting illness, where care is currently focused on comfort and symptom management rather than curative interventions, and patients that present with goals of care and consistent treatment in place. And that the symptoms that we find are considered or related to palliative conditions. And we'll go a little bit more into how you can document this in your EPCRs should you find or meet patients that present as palliative going forwards. So what have we done within dispatch? We created a EOL timestamp. So that's end-of-life timestamp. So when the call takers identify these 911 calls coming in, they can timestamp the call, and that flags a notification to our clinical desk where our paramedic specialists sit, and it alerts them to look at that call and interrogate a little bit more. And during that call, we dispatch the ambulance, but the paramedic specialist can actually call back the family or the care team and start to ask a little bit more questions. Could you please make your most or goals of care available to the crew? That's often when we find out if they have a most or goals of care present. And what that allows our paramedic specialists to do is support the attending paramedics and arm them with that knowledge and support them in their decision making if the patients either don't happen to have one, or if they do, ensure that that's the route that we're going to continue to go down in providing care to that patient. We also have our nurses in secondary triage that are able to interrogate these calls and provide support where necessary, with the view that, again, we can connect collaboratively with the local community care teams if they have one. What are we doing for palliative education? So this is the education pillar of advancing practice. So currently, all of our community paramedics and a number of our advanced care paramedics, including our EPOS doctors, have undertaken LEAP training, which is a course that's provided by Palliative in partnership with the agencies that Jennie mentioned at the beginning of the presentation. What we've done so we can ensure that this education is rolled out to the masses is Jennie's been working with Palliative to create a specific BCEHS LEAP program that's very much aimed towards our primary care paramedics and separately our advanced care paramedics that really looks to focus on operational scope of practice and what we can offer within their own homes. Online on the Learning Hub, there's also the MyGrieve Toolbox, which is well, across Canada, really. It's a Canadian resource that's been developed in partnership with Alberta Health Services and a number of other organizations. And both myself and Jennie and a number of other people have contributed to that as reviewers to ensure that the curriculum aligns with the best practice of what we want to see in the organizations going forwards. And the final piece, which is going to be live very shortly in March, is going to be the Assess, See, Treat and Refer Palliative Clinical Pathway course. So this basically pulls together all of the pieces of information as to how we're going to leave these patients at home safely, how we're going to follow the pathway that's been laid out by BCEHS in partnership with the health authorities, and the requirements that us as paramedics need to ensure that we fulfill and document to be able to leave these patients at home. What Jennie has done as well as created the new BCEHS clinical practice guidelines. So if you have all got the handbook and you've downloaded the handbook, if you go into the treatment guidelines section and then go into the adult guidelines section, you'll find a specific area of CPGs called palliative and end-of-life care. And here you'll find 6 new clinical practice guidelines that have been live now for around 8 to 12 months. And these specifically will look to provide direction on the various symptom managements that you can do. So in this case, we've got pain for a palliative patient. There's some background additional treatment information, and you can kind of scroll through and look what you're able to provide as an intervention within your scope of practice working for BCEHS. And a lot of what we find is often comfort measures initially and relieving anxiety with patients. But otherwise, there are some pharmacological approaches that we've still got for our ACPs, which subsequently may need Schedule 2 endorsements on your license. But if you haven't had a look at these clinical practice guidelines, or you don't know that they exist, we encourage you to do so. They're some of the first in Canada to be actually developed specifically for palliative patients. Again, they've been developed in partnership with Dalhousie and with the BC provincial group for palliative care. So everything is in alignment with what other areas of the province and organisation are doing, so we deliver that consistent level and standard of care. And then we've been developing education that meets the legal scope requirements. So in some cases, there are medications that patients have in their palliative home medication kits that we don't actually carry on our ambulances. And to be able to administer those medications, a lot of the advanced care paramedics actually need a Schedule 2 4B endorsement, and there's a separate training package for that, which you can find on the Learning Hub. What that allows you to do is actually deliver any medication to a palliative patient under the direction of EPOS once you make that call through clinical. So it just allows us some greater flexibility in the delivery of care for these patients, and means that we don't have to carry every single medication in our bags during a crisis. We're also currently working on a subcutaneous line and medication administration with the ACPs and with our CP cohort. They see a lot of palliative patients in their communities, and this is another area that we want to kind of branch out into, so we can really ensure that we have all the tools available to provide the care that's required. And then what are we doing to leave these patients at home? So this is really kind of the bit that Jennie and the team and myself spent a lot of time working through, and what we've spent a lot of time working with in partnership with the health authorities. As Jennie mentioned, for many, many years, we've taken patients to hospital, and those that refuse to go to hospital are often left disconnected from their primary care or from any care teams. So a real big piece to how we mitigated the paramedic practice to be able to leave these patients who were home was, how do we share this information with the community care teams and make them aware that we as BCEHS have attended their patients in their community, and how do we connect that patient back to the care team so that either the community care team can send out a resource or response, or at least maybe that we've actually managed to keep the patient at home, settled all the family, and maybe there is no follow-up. But navigating in the dark is one thing. So how do we increase visibility on that? So we've introduced clinical pathways to BCEHS, and so this is a new terminology that's going to be rolling forward as we develop new initiatives. But just a bit of a high level, what are clinical pathways? You could view a clinical pathway as an evidence-based guide in which patient care is aimed to be optimized based on the resources available to us. So the clinical pathways that we've got developed going forwards will be both medical, trauma, alternative destination, and SSC treat and refer. So to kind of give you some examples of medical clinical pathways where we know that evidence supports direct transport to some hospitals, we've got stroke clinical pathways under development and some new ones due to be released down the sea to sky currently. We've got STEMI clinical pathways that are currently rolling out. We've got the new trauma guidelines that have been around for the last 12 to 18 months. They're part of trauma clinical pathways. And so building on that, this new area of clinical pathways will be the SSC, treat and refer. And this is what we'll be using as the umbrella term to ensure that we can leave patients at home safely. And palliative is the first stream of this. And so that's to give you a little bit of an idea as to where the terminology came from and what that means in our practice and language going forward.
Okay. Sometimes I wish I had an accent like Leon because it's more fun to listen to. Just make sure everyone's mics are muted, please. There's some feedback happening here. And one of the reasons we were able to implement clinical pathways is that our senior leadership worked with the Ministry of Health to receive ministerial orders that allowed us to move away from that we must always transport. And the amendments around the ministerial order essentially allow us to either A, not transport, or B, transport to alternative destinations. And when we choose to do that, we have to have appropriate guidelines in place. And that's why all of these other pieces are coming into play. We aren't permitted to just go into somebody's home and decide that we don't need to transport them. If that's the case, and if the patient does not want to be transported, we have the refusal pathway. But what we truly are talking about is designing pathways that are informed and accepted through our system of care and that allow patients to safely remain at home after they've been appropriately assessed, and also that that is their choice. So some really important pieces to fall out of that. So as Leon mentioned, this is the first pathway that we're developing, and it falls under the SSC, treat and refer umbrella. Now, what we are rolling out in phase 2, which is starting in mid-March, is a prototype for each of these 5 communities. So Prince George, Nanaimo, Kamloops, North and West Vancouver, and Abbotsford will all have the technology embedded so that they can enter into the referral piece. Now, the referral piece means that if you are leaving a patient at home under the palliative clinical pathway, there will be an automatic notification to that patient's care team so that they will know in the morning when they come into work that BCEHS was in the home, that they administered medications perhaps, or they intervened somehow and the patient was not transported. So the ministerial orders that we received asked us to make sure that we were letting other bodies of care know so that that patient journey is more complete. And this is how we're doing it. So we've embedded technology inside Siren that allows those healthcare teams to be notified that we were in the home. So that is why we only have these 5 communities working as prototypes. And that's also why we're asking that the palliative clinical pathway, although you can see it on Siren, don't use it unless you're in one of those 5 trial sites. It will be made very clear to you if you are a participant in one of those 5 trial sites, and you will be trained appropriately in how Siren looks within that. So Prince George, Nanaimo, Kamloops, North and West Vancouver, and Abbotsford are the trial sites, and those paramedics that encounter a palliative patient at home, and Leon mentioned the inclusion criteria earlier, so any patients that fit that want to stay at home, that are appropriate to stay at home, you will be able to treat them, and then we'll walk you through the Siren piece. And you'll also get specific training around that. And in the morning, when that care team comes into work, they will be notified that you were there. And essentially, they'll see your entire PCR, so they'll know what you've done. And the improvement in patient care will be easily recognized. So let's break this down a little bit. Part of the challenge of late is truly identifying what is a palliative patient. The trajectory of what makes up a palliative patient is huge, the inclusion criteria. So for us as BCEHS, to be really clear, we're responding to these patients when they call 911. We're not identifying patients out in the community and deciding that they're palliative. They already are. So we've created clear inclusion criteria that is embedded in the clinical practice guidelines. So when you walk into a home and perhaps you see a hospital bed and you see a patient who appears to have a terminal disease and they are short of breath and they fit that inclusion criteria and they would like to stay at home, and perhaps it's important also to make sure they have the support to stay at home, then you could assess them appropriately and they could be included in that palliative clinical pathway approach. You'll then treat them according to the clinical practice guidelines. And bear in mind that Clinical, all of the paramedic specialists and the secondary triage nurses have all been uptrained in palliative and end-of-life care. So if there's any concern around an approach to take, what we're really advocating for is a collaborative approach. So reach out to Clinical. Before doing that, have a look at the patient's records if they're in the home. And if you're able to contact that care team that usually sees and treats that patient, they are your best point of contact. So collaborative care, as we all know, is a little bit new to BCEHS. I think we're accustomed in the past to going in and having the appropriate tools to assess patients and resuscitate patients and then transport them appropriately. And in this case, we're presenting something that's a slightly different approach to care, and that is collaborative care, and which is why one of the reasons we've spent a considerable amount of time making sure that the health authorities are available to us and that those care teams are available to us when their patients call 911. So one of the pieces around this is asking each health authority to make sure that any pertinent patient information is kept in the home. What we're asking for are the green folders with the appropriate forms inside them to be put on the side of the fridge. And so as a bit of a flag and a signal to paramedics that they can go and find those forms and begin the process. So calling first to that care team is really key if you cannot access that care team. And it's quite possible that in the middle of the night you will not be able to. That's where Clinical could well be your friend. And then once that's managed and your patient is appropriately symptom-free, then you can enter down this referral pathway within Siren. So that's the pieces of Assess, See, Treat, and Refer. We've built an entire course around that will be available on the Learning Hub, first to the 5 communities, and then we'll be releasing that more broadly. So it walks you through each piece, and it walks you through Siren so that everybody understands the appropriate buttons to push, etc. But fundamentally, this is the biggest change to our practice. The other ministerial order that we received was an ability to not have to transport all patients to hospital. So when we looked at our BCEHS data and we transported hundreds of patients to hospice last year, each of those patients were first going through the EDs and then as a secondary redirect to hospice, which is an interesting approach, but we know now we can change that. So if your patient has a reserved bed in a hospice, what the approach is that you can now transport that patient directly to hospice. You need to call first, make sure that they're accepting that patient, and then you can transport directly without going through ED. And that is available to all paramedics all over the province. So to cycle back to the very beginning of the project where we mentioned that we are funded by Health Canada, CPAC and CFHI, there are a number of indicators that we have to report back on, and also indicators that we've added in here for our own internal purposes so that we can track and evaluate how the implementation of this A-STAR approach goes. And with the intention that in future we'll have other patient presentations that will also fit A-STAR. But first we have to make sure that we do a robust evaluation. So some of the pieces that we're looking at, and this is not all of them, but understanding paramedic knowledge of palliative care. Have we actually presented the appropriate education? So everybody that participates will be asked to fill out questionnaires, et cetera, attend likely more of a forum style for us to evaluate whether the knowledge that we provided was acceptable or not. We'll also be contacting patients and families to understand if the care that we provided met their needs. From our perspective, of course, the number of palliative calls to 911, we really need to get a handle on understanding that. Was our symptom management appropriate for patients? And one of the biggest pieces of all of this is were we able to reduce non-conveyance to hospital? So were we truly able to keep palliative patients, end-of-life patients at home and avoiding the ED admittance? Time committed to calls is interesting, and we'll get into that in a moment. But how does it look when we go into patients' homes and we spend perhaps a little bit more time assessing them, treating them, entering into the referral pathway, as opposed to going into homes, assessing, treating, and transporting? So we call that total time on task. And internationally, that's become a really important indicator for all paramedic agencies to truly understand. Referrals made, that's the number of patients that we're referring back to their care teams to come in and follow up. The goals of care documentation, this has become a really interesting topic in the province. And as you would all know, every health authority has a different MOST form, for example. BC Cancer has their goals of care forms. We have the DNR form. There's an expected death in the home form. So what we truly want to understand moving forward is, are those goals of care documentations, in whatever form they are they available to paramedics in the home? And in the manner that they are available, is it appropriate? Do we need to add more to those forms that would make our jobs easier? And then the 911 recontact rate. So when we treat patients and transport them to hospital, we're reducing our risk enormously because the end result is a full workup at the ED. So when we leave patients at home, how do we measure and evaluate that we're still being safe? And one of the ways that we do this internationally and that we're adopting as well is to understand that when we don't transport patients, so we enter into a non-conveyance, are those patients simply calling 911 back that day, the next day, 3 days later? So we've begun tracking this so we can truly understand, are we being effective, efficient, and safe and meeting our patient needs? So we started an evaluation for any patients that were identified as palliative using the palliative impression code, which is a new entry into Siren. So we looked at 317 patients from July 1st through December 31st, and that should read December 31st, 2019. And we saw a 70% improvement with those patients. And then we broke it down to what those top 4 interventions were. And the first intervention, interestingly, is patient positioning. So what this is telling us is when we go into these patients' homes, it's not necessarily about the medication administration. And what we're unable to capture, but which you would all know very well, is it's also about patient education and calming the scene and the leadership that you provide in those moments and explaining to the family what is happening. And we can't capture that right now in Siren, but we know that that is also happening. So patient positioning was the first intervention, followed by oxygen administration, normal saline. We see a lot of patients who are experiencing nausea, vomiting, etc., and that seems to be where normal saline is being used. And then medication use and administration. And then we're breaking down the medication administration further. And as Leon mentioned, it's not possible for us to carry every single appropriate palliative medication on ourselves and in our ambulances. So we approached the EMLB with a scope expansion, and we were successful there. So just to reiterate, an ACP who's taken the course that's online in the Learning Hub and has the endorsement can administer any patient-prescribed palliative medication that's found in the home, so long as they've called EPOS. So this is significant. A lot of palliative patients, the most appropriate medication for them, for example, that have nausea, vomiting, it might not be gravel. It might be an alternative medication that they've been prescribed. So in these instances, if you're able to administer that medication, you can. Again, using the same evaluation pre-launch, we know we had 317 impression codes, and that's where you find the palliative impression code is on the left there under the siren column. We know that our non-conveyance rate of those patients that were chosen with the palliative impression code was 15%. All 911 calls within BCEHS using the same methodology. So when you choose to not transport, there are 6 options. So what we're looking at here is our denominator is simply those patients who refused care, or alternatively were left at home under the palliative impression code. So what we're trying to say here is that our non-conveyance rate of palliative patients at 15% is slightly higher than all the 911 calls taken together that were not conveyed at 12.8%. So what we'll look to do is eventually identify an objective for that 15%. What rate can we get to that's still safe and effective? But that's our starting point, is 15%. And the last 2 columns there, we're looking at transport, time on task with no transport versus time on task with patient transported. So when we first began this project, we spent a lot of time looking at the literature around the world in terms of how does it affect time when paramedics go into home and do not convey patients and still treat them. And what we found, we had to prove this to ourselves as well, but what we found was when paramedics are on scene and transporting patients, it takes slightly longer overall. You can see the average per call is 82 minutes. Whereas when we go into the home and we do an appropriate assessment and we don't transport with palliative patients, it's 52 minutes. So that's a significant difference, and that's supported by international literature. So we'll spend a little bit more time on that in the next 6 months to truly break that down, and we'll share the results. But again, this is our baseline where we sit today. Now, I mentioned the 911 recontact rate, and in a sense, that's a proxy for safety. So the 24-hour recontact rate for palliative patients left at home was 0%. The 48-hour 911 recontact rate for palliative patients left at home since July 1st is 0%. The 7-day 911 recontact rate, which means that the palliative patient left at home or their family caregiver called 911 back sometime between 48 hours and 7 days, and that rate is 8%. Now, when we compare that to all of our 911 patients calling 911 that are left at home via the refusal pathway, we know the 24-hour recontact rate is 0.4%, the 48-hour recontact rate is 0.7%, and the 7-day recontact rate is 4.7%. So to give some context to that, NHS London, which has been doing this work for a very long time, has a recontact rate of between 8 and 10% for all of their patients, to give that some context. That ends our formal presentation, and I think we're ready to take questions, comments, etc. We have to open it up somehow, or they just chat away?
I have a question. So thanks, guys. Awesome presentation. Do you have a sense of, for when you're assessing if there is a MOST form or a goals of care form at the home, how many times palliative patients do not have that?
Mm-hmm. We didn't include it in there, but it's around 50%.
Half the time.
Half the time. So it's very low. Another reason we've developed these relationships with health authorities is that so that we can go back and explain that feedback. Right? We already have those relationships. So we have gone back. We have explained that this is 50% is inadequate for our needs. And that's where this conversation went. It's a huge gap. And they didn't know it because it's not something that they track. And that's where the conversation has come up to say, they've essentially said back to us, what can we do better or differently? And we said, put everything you have on that patient in a green folder on the side of the fridge. And that is it's an easy message to communicate. And it's so helpful for us when we arrive on scene to be able to go to one place and pull those forms. Yeah. It's what we have managed to pull out and tease out has been fascinating.
Question for you. A common scenario I've run into on the street is that patient who's been identified by their primary care physician, been referred through to a palliative team, is at home waiting for that phone call back, and now they're in extremis with shortness breath, pain, whatever it is, and they present to us, are often interested in this sort of pathway. I know it's early days right now, but is that essentially still applicable even if they haven't truly had contact with that palliative care team yet?
Absolutely.
Okay.
Yeah. So the question was if a patient is, and it's called an unconnected patient. So a patient has been diagnosed as palliative or terminal. They're in the waiting period, which is approximately 2 to 4 weeks, depending on where you are in the province, sometimes slightly longer even. They've gone home, they've had an acute crisis. So when we took an initial look at the data, we saw about 25% of our calls were those patients. So a significant portion of calls. So when we discussed this with health authorities, we had an approval to include those patients in our referral process. So they will see both connected and unconnected patients within those 5 prototype areas for now, and then we'll figure out a more efficient way to help them move forward. Some of it is about the identification of what the components are in some. They haven't had a reason or an ability to access that data in the past, and now we're providing it to them. And for them to react quickly is a challenge, but they are now aware of it. And so they're working on their end to increase their ability to respond to those patients, essentially, and to try to shorten that gap time.
Probably worth mentioning that, so that clinical pathway, if they are unconnected, then you can consult with clinical and/or EPOS, and that's the substitute for the missing care team at that point. So it's basically just having someone else to run your plan by. And in consultation with the family in those discussions, what the agreed plan was, and just kind of making sure that that's seen safe with a peer. And then for awareness, the way in which we've got Siren set up with the portal and these referrals, we're looking at literally an hour to 2 hours notification. So within an hour or two of you leaving scene, that's how fast we're managing to get this information through to the health authorities and the community care team. So there's not a lack. If it's a call that you've attended maybe at 8, 9 a.m. in the morning, they should probably have that by mid-morning in some cases, and this is what we're kind of all working towards. They might be able to respond to that themselves within the community by 12 midday. So that's kind of really the system of care that we're trying to build going forwards.
One other question I had, just with that, that's like secondary presentation to 911 within those different time frames. Is there a plan to sort of subgroup analysis of those? Because I feel like not all of those cases are necessarily indicative of a failure of our system or of our initial treatment and assessment in that.
Absolutely. And I hope I didn't present it as the question is, thank you, Sandra, is around the 911 recontact rate, and will we subgroup analyze that? And to be clear, the 911 recontact rate, when we're looking at it acts as a proxy for whether it was appropriate, but it's actually not necessarily, right? The way we now have to structure it is, what are other agencies doing? And luckily other agencies are already doing this, so we can fit ourselves into what would be appropriate, because we truly don't know yet. And that's also why I mentioned NHS's recontact rate. So what it tells us is some of those patients are calling 911 back, but the delay before they are calling 911 back is significant. It's 7 days essentially, which may just be another acute crisis. Truly what we'll drill down to is the 24 to 48 hour recontact rate, and then we'll look at why they recontacted 911, which is, I think, really your question. Yeah. Why are they recontacting 911? I do not believe we'll stay at 0% for 24 hours and 48 hours. That seems very optimistic. But as a starting point, it's fantastic. But where exactly we land and where our key performance indicators direct us towards, we don't know yet. But we are looking at it very closely, and we'll understand it for our system as well.
Any other questions in the room or online?
Alex from Invermere. We have several questions here in the chat boxes. I don't know if anybody's reading them at all, but it's mainly about receiving most on scene or which not necessarily refers to palliative care patients, but and as well, if you can expand a little bit more on what is being done or what will be done in rural areas where we're not still involved into that pilot project.
Can I just get you to repeat your first question there?
My first question is about DNR forms, no CPR, basically a most MOST score on a lot of patients, not necessarily our palliative care patients, but we need to intervene on scene or not intervene based on that form, and we rarely get it on time.
Yeah, thank you for repeating that. Around the MOST forms and the DNR forms, as mentioned, they're lacking in a great part of the province, so they do make the job challenging. MOST forms also came from an in-hospital perspective, and we are applying them to our work. So there are some challenges in translation there as well. Essentially, if a patient has a MOST form in the home, and I hope this answers your question, but if it doesn't, you can clarify. If a patient has a MOST form in the home, that means they've had an informed conversation with their primary caregiver, and we as paramedics are under obligation to fulfill the request on that MOST form. So depending on your scope of practice, not all paramedics would be able to intubate or not intubate, which is one of the big pieces of the MOST. But generally, the MOST form is appropriate for use where patients are in cardiac arrest and you're making the decision around resuscitation or not. So I don't know if that answers your question. If they have a MOST and they do not want resuscitation, it is your obligation to respect that.
It partially, that's Alex again from Invermere, it partially answers it. It's just the fact that sometimes there is a MOST, but it's not available on scene. And so the crew has to start CPR or it has to intervene and then get that information later on from the hospital, and that might create a conflict.
Yeah, I understand what you're getting at there. So Ministry of Health is very clear, and it's in this latest March practice update as well as the February practice update. There's a series of Q&As that we are working to clarify with BCEHS because they apply to us. So if you have reasonable grounds to suspect that there is a MOST form, then you must respect the MOST form. It's not around actually having that in your hands. Now, we recognize this is a significant departure from the past, so we're working quite hard to clarify this and make sure that everybody feels comfortable. What I would suggest, if you're not comfortable, is to contact Clinical, and they will help you. If Clinical can't help you, then they'll take you through to EPOS. These are important conversations to have, and considering that we're in a period of transition, this is one of the pieces that we are really working hard to clarify for everybody. So your question is very well posed, and it's at a timely moment. And I would just ask everybody to recognize that there are many changes happening, and this is probably one of the most important pieces, is the recognition from paramedics that if you have reasonable grounds to believe that a MOST form DNR exists, then it is our obligation to respect that. Did you want to add to that, Leon?
I was going to speak to your second question, Alex, which was what we're doing about rural and remote for these patients. So as I mentioned at the beginning, unless you just recently joined us, all the community paramedics have been provided with palliative education, and palliative patients are actually a patient population that they now see as part of their daily client visits and their scheduled visits in their communities. The idea of that is that obviously they can keep a tab on these patients generally and a closer eye on these patients day to day, and they're that conduit between us and their care teams where they partner. So that's kind of the focus there. We aim to get into more rural and remote areas with the CP initiative. There's over 100, 110 CP stations, and that's the strategy for how we're going to manage these patients in rural and remote. At future state as well, hopefully, is that the community paramedics as well as people on station, we'll have local champions and clinical leadership in those areas, and they'll be able to support people like yourself and others with how to make these decisions and provide care for these patients.
I appreciate it, Leon. I appreciate it, and I think it's the right direction. It's just that where I live right now, we don't have a CP, and it just feels that the CP program has stalled in a way, and we need just more CPs in other rural areas than the one that has been established already.
It's a good question. The evaluation from CP has been shown to prove benefit in all these communities, and obviously it started as a trial and a good initiative many years ago, and the intent is to continue to grow that in other areas of the province. Now we've proven that it has a place within the healthcare system for paramedics.
Thanks.
Any other questions online? If not, then we'll head over to Jennie's second presentation.
You guys good for questions?
Yeah, all good. Thank you everyone for the first part. Seamless.
Yeah. So this was a presentation that we gave to PHSA board, and this is on out-of-hospital cardiac arrest and STEMI. And we thought it would be helpful and interesting to share it now as well. So bear in mind that this was to the PHSA board members, so we started off with a really quick discussion and orientation, and I hear some laughing, and this is really important, I think, that as a population we understand intimately the difference between a heart attack and a cardiac arrest, if only to help people recognize that a cardiac arrest needs CPR and defibrillation, and a heart attack likely needs a call to 911, and the different patient presentations. Now, this piece of the presentation was reasonably well received, and I found that quite interesting. So let's talk a little bit about our cardiac arrest data. This is almost outdated already, and I think we're only in February. But generally speaking, we attend to over 6,200, almost 7,000 cardiac arrest patients. That's all etiologies, all causes. And this is the most cardiac arrest cases that we've ever attended to. We know provincially we have a median response time of 8.5 minutes, and that's the entire province. And it's probably no surprise that the vast majority of cardiac arrests are occurring in urban areas, with 18% in rural BC. So bystander CPR, as well as bystander AED use, is showing to make the biggest difference in people's lives. So this is a big piece of our work of late, is understanding, first of all, what is our bystander CPR rate and our bystander AED use, and also how can we increase this. So bystander CPR at 41% has increased almost double over the last 5 years. So people are learning that they do make a huge difference in people's lives, and you can see the difference in resuscitation rates when there is a bystander doing CPR as opposed to no bystander. We also know that the public AED usage, the increase in availability of AEDs is also helping. But interestingly, in 2019, only 2% of all of our cardiac arrests involve public AEDs. And again, when those public AEDs are used, we see improved outcomes. So those two pieces together are really important. So that first call to 911 is also where that true first response begins. So the call taker or the dispatcher is receiving the call, and it's a confirmed cardiac arrest. The call taker or dispatcher moves to telephone CPR instruction almost immediately. And that's where we're seeing huge changes in outcomes, is the sooner we can identify that cardiac arrest and the call taker and dispatcher begins their CPR instruction, the better the outcome. Now, the other piece that we've done lately to make sure that the call taker can see where the AED is, the closest AED, is that we've revived the provincial AED registry. So that's a registry that tracks the location and number of AEDs throughout the province and then links those AEDs right into CAD, so that when the cardiac arrest has occurred, the call taker dispatcher can see where the AED is, and if there's ability for that caller to go and get an AED or to have somebody else run and get it, they're able to organize and orchestrate that, and that is making huge differences. For those of you that have PulsePoint on your phone, and for those who don't, throw it on there. This will tell you if there's a cardiac arrest within 400 meters that's in a public location. Your phone beeps really loudly, you cannot miss it. You accept it, and then you will go to the location of where that cardiac arrest is. We've also seen great increased outcomes from using PulsePoint. We're entering into a research project with PulsePoint starting in the next few months, where they'll look at the outcomes associated with patients that had PulsePoint activation compared to those who did not have PulsePoint activation. So this will be a cross-Canada initiative and involving some agencies in the U.S. as well to really look at outcomes from using technology to enable bystander CPR. At the end of the day, that's what that's about. So as I mentioned, the provincial AED registry, we've revived that, not only so that the cardiac or the call taker can see where the AED registry is, but it also shows up on your phone if you have the PulsePoint app. So when you get that notification that there's a cardiac arrest in a public place within 400 meters, you can also see where the closest AED is. So you'd be able to communicate that to somebody in your presence to go and get the AED. Here's the location. I will go and begin resuscitation on those patients. So again, I encourage you, if you don't have that app, please do download it. It's free, and so few things are. So let's talk about survival. In BCEHS, we have some very impressive survival rates. So all-comer survival refers to all patients, all rhythms. And this is outcome data, so 30-day neurologically intact survival, which we get from our health authority partners. So across BC, we have an all-comer survival of 16.3%. Now this is out-of-hospital cardiac arrest, which means we as paramedics are involved in these calls. Our Utstein survival, which is a smaller subset of patients that includes witnessed and shockable, initial shockable rhythm patients. Now the cardiac etiology is being phased out of Utstein, but we've included it there for now, is 39.2%. So when we report on Utstein survival rates, what that means is that we can compare to other EMS agencies, which is really important. We're all speaking the same language. We all use the same denominator. And so we're shifting our language towards using, we won't drop all comers, but truly we'll start talking about Utstein, because those patients have the best chance of survival. And when EMS agencies around the world approach cardiac arrest patients in the same manner, you would then expect survival to be similar. And we'll talk more about how we compare in a moment. The cardiac arrest registry data has changed our lives a little bit, I'd say significantly, when we go to talk about our results. So when you fill out Siren and you've resuscitated or not resuscitated a cardiac arrest, you will enter into the registry by answering the question, was your patient ever in a cardiac arrest? And then the series of questions that you then answer are used to inform all of these numbers. So it's really critical. Your role in this is very critical. And then, of course, we share data with CanRock and other researchers that come to us almost weekly, if not monthly, for our data. We're a huge organization, as we started out by saying, there's 700,000 calls a year. Almost 7,000 of those are cardiac arrests. There are very few other paramedic agencies around the world that respond to that sort of volume and have the quality of data that we do. So how do we compare around the world? On the far left is BC. These are our Utstein survival outcomes, so we're just short of 40%. To the right is Australia Ambulance Victoria. So one of the interesting pieces here is comparing agencies that respond to similar volumes. So the yellow, Ambulance Victoria, they respond to 6,400 cardiac arrests a year, and their survival outcomes are just slightly lower than ours. In the middle, in the purple there, is Leon's hometown, London Ambulance Service. They respond to close to 11,000 cardiac arrests a year, in insane numbers, and their outcomes are just slightly less than Ambulance Victoria, as you can see. In the green is Seattle King County. They respond to 1,300 cardiac arrests a year, so significantly less. but their survival outcomes are tremendous, as you can see by that big green column. So we look closely to them to see what they're doing, to see what do we need to change in order to meet or beat them. So this has been an ongoing piece of work for us. And then on the far right, in the salmon color there, is St. John, New Zealand. They respond to close to 2,000 cardiac arrests a year, and you can see that their outcomes are around 33%. Utstein. We have worked closely with the Global Resuscitation Alliance. They invited us to join them, and all of the pieces that they requested there, the established cardiac arrest registry, telephone CPR, we've built a high-performance CPR course, rapid dispatch, measuring ourselves, that's a really big piece of that, AED programs, technology, accountability, etc. We've implemented all of that, and we invited them up here to run a workshop in June of 2018, and we'll be inviting them up again and expanding it more provincially so we can share these learnings. So let's switch the conversation a little bit from heart attacks, or from cardiac arrest to heart attacks. And the messaging here is that cardiovascular disease is a huge killer in North America, and heart attacks and cardiac arrests are not solo. One can lead to the other. So one of our other big focuses is on appropriately managing STEMI. We can recognize STEMI in the field, and perhaps we can work on changing our approach to STEMI. So in Kamloops, last year we started a trial called the CHAMP trial, and this is providing the advanced care paramedics in Kamloops with pre-hospital fibrinolytic medications. And when they have a confirmed STEMI now, in consult with the cardiologist, they are able to, if the patient meets the inclusion criteria, administer fibrinolytics. We had our 6th enrollment last week. They've all been very successful, and early data shows us that we're reducing time to needle, that's what time to fibrinolytics is termed as, by close to 50%. So very significant differences when we're treating patients out in the field with pre-hospital fibrinolytics as opposed to transporting them to hospital. So once we have that project complete, and that is 10 intakes, then we'll reevaluate the data, and we're working to move that out more provincially than just Kamloops. But the Kamloops paramedics have done an amazing job of participating in this trial, and the patient outcomes for being able to participate in this trial are equally amazing. A couple of the patients were really sick when paramedics arrived on scene. I mean, they're all really sick, but a couple were really obviously sick. And by the time they arrived in the hospital, post-fibrinolytics were much improved with full perfusion. So the other pieces that we're looking at for future education training, et cetera, is high-performance CPR training for all paramedics. Leon, Tim McCready's, Richard Armour, they've all been really working hard on creating a course for all of BC that will really dial down to making sure that we're all doing an approach towards resuscitation that fits international standards and meets our goals. And then the other piece that's become really important, of course, is talking about scope and providing appropriate equipment so that we can better diagnose STEMIs and heart attacks using the PCP license. So there's lots of discussion happening here, and I'm sure it's no surprise to anybody that funding is the main obstacle. But the conversations are ongoing, and because our performance and our outcomes are so positive, the conversations are really fed by that. So we'll end that there, and again, open to any questions.
Jennie, a couple. What is our definition for survival for the stats for all comers versus
30-day neurologically intact.
Okay, cool.
Yeah.
And second one, from an inter-facility perspective, we move all these post-arrests all the time. If we're filling out that category, are we entering full data?
I'm just going to, I realized I didn't repeat your first question, so I'm just going to repeat it so that they can hear. What was the outcome measure is 30-day neurologically intact survival to determine what our outcomes are. And then your second question, sorry, can you repeat that?
So just from a critical care transport facility perspective, if we are filling out for all these post-arrests that we're moving, are we entering duplicate data? Or
so post-arrest patients should not be entered in. Okay. If it was an out-of-hospital cardiac arrest, the originators of the the original paramedics that responded to that should be filling that out as opposed to post-resuscitation. I understand where it comes from and that the question says, did the patient experience a cardiac arrest? So I can see why we would go there. But truly what we're looking for is collecting the initial rhythm, the time on scene, was it public AED used, et cetera. So that's really specific to you being there and part of that initial resuscitation.
Thank you.
You're welcome. Thank you. Any questions from anywhere else in the province?
Alex from Invermere again.
Hi. Hello, Invermere.
My question is how much the survivability numbers from the rural areas change the overall numbers, because in urban areas our response time is so much shorter, and therefore, I suppose that survivability is more likely than in rural areas where you can have more than an hour of a response time, and therefore the survivability of a person will be lower. So yes, we have 18% of cardiac arrest from rural areas, but what's the survivability of those 18% and how that changes the overall numbers?
I love how you don't ask easy questions. The short answer to your question is that we have not done a subgroup analysis of the 18% of patients and how they compare, which is I think what you're asking. What are the survival outcomes of the 18% of those cardiac arrests? And you're quite right to point that out. We haven't done a subgroup analysis of that, but we will be doing that in the future, and we'll share those results back with you, because as you rightly point out, they may be vastly different. The other piece that is different throughout the province is the receiving facility. So one of the reasons we really talk about return of spontaneous circulation is that that doesn't involve a hospital outcome. When we measure hospital outcomes, when we're talking about 30-day survival, we're also measuring the patient experience as they went through the hospital system, and we have very little control over that. So when we talk about time, we are indeed measuring also what destination hospital did your patient go to, and what equipment and facility was available to that patient. So we're working on subgroup analyses, but those are big pieces to tackle. Does that answer your question?
It does, and I think that's why the initiative that Leon mentioned with expanding the PCP scope of practice and kind of recognizing standing on by PCPs is that's going to, in my eyes, it's going to make a huge difference in those numbers in rural areas.
Well, we believe that you're quite right.
Jenny, one other, it's this sort of big just theory question, but do you see an appetite in the future for a post-cardiac arrest pathway in the larger urban centers in terms of like dedicated post-arrest receiving centers like we have STEMI, trauma, et cetera?
Yeah, great question. The question is, do we see post-arrest care pathways in the future? And I think the answer to that is absolutely, 100%. I think Sandra's probably been working on that as well.
Oh.
And yeah, it's really important that when we start to pull out a little bit to see what affects the patient journey at every step. And that's obviously really where when we move it away from the emergency moment, we know that that post-arrest care is actually the most important. If we've successfully resuscitated our patients, what steps are we now taking? And I think we haven't in the past perhaps put enough attention on that. But
in a way, we in a form see it already being researched out of the ECPR trials in St. Paul, but that would be an example of what you're talking about. Right. So I also agree with your sentiments, and I think it's a future goal.
So it is worth mentioning that Jenny talked about the high-performance CPR course. That's going to start getting rolled out on April 1st this year, 2020. It's going to be included as part of the new CPD education format that BCEHS Learning is developing. A couple of names there. That was Richard Armour, Tim McCready, and Ryan Ackerman have been involved as a large group driving a high-performance CPR curriculum, as well as the learning team with the rest of the curriculum, which is going to be focused all around cardiovascular assessments, both for adult and pediatrics. So Please keep an eye out for those future dates. Please make sure that you're enrolled. Keep an eye on the ops updates as well. BCEHS Learning and Clinical Medical Programs are taking a new approach to ensuring that all paramedics in the province are signed up to ensure that they've got that education received so that they can practice within a full scope and ensure that we're delivering a consistent standard of care across the whole province. So keep an eye on your inboxes. Please enroll. It's really great curriculum. It's a new format. We've been getting some positive feedback. We'd like to hear from you as well. So please just email in, and thank you very much.
Thank you, everybody. Appreciate your time.
Okay, so we'll switch gears just quickly here. So, yeah, we'll just take a few minutes to get set up here. So we welcome today second-year medical student Jordan Ewan, so almost Dr. Jordan Ewan. Yeah, short while away. And also BCEHS paramedic as well. So he's here today to talk about one of the projects he's done. So welcome, Jordan, and we'll just get your presentation set up. We'll start in a few minutes.
All right, well, good morning, everyone. Thank you for having me and allowing me to present here today. As mentioned, we'll be switching gears and going into having me discuss a qualitative research project that I've been involved in about the experiences of paramedics during overdose response. I wanted to start with a bit of a personal introduction, talk about kind of where this project came from. And as mentioned, I've been kind of wearing two hats during most of this project. The first one is as there we go. Part-time paramedic. So I'm no longer employed by the service, but I was for only about 3 years. I was hired as a part-time EMR and put out into Station 321 Lytton. And then a year after that, I started my PCP training. And part of that training involved 2 blocks of shifts of precepting at this station here, which we might recognize as 248 East Cordova. And it wasn't a lot of time there, just 2 blocks, but I found my experience there very eye-opening. You know, it was really great to learn the clinical skills, but also just to talk to paramedics and see the rate and the types of calls that these folks are responding to. And, you know, a year later, I started the more training as an MD undergraduate. This is what Google suggests when you type in medical student, so I went with that. And when I started that program, kind of 2 things came to mind. And the first was that my time with BC Ambulance was coming to a close, but also that the program offers a lot of opportunities to engage in formal research. And when I started looking around, I was quite surprised to see that there haven't been any studies that directly focus on the impact of the overdose crisis on paramedics. And that was surprising to me for, you know, because having only seen a little bit of that experience at 248, it's just immediately apparent, to me at least, that paramedics were on the front line and talking to these folks how their experiences have changed over the last 3 years or so. So I kind of took this as an opportunity to, I guess, focus on something academically a perspective that hasn't really been focused on yet. And so that led to this kind of very broad research question, which is about exploring the experiences of paramedics. And here we go. And we can think of experience as having 2 components. We think of this cognitive aspect, so this is what we're thinking during an experience, how we cognitively interpret something that has happened, as well as an affective component, which is how we emotionally respond. How does an experience make us feel, you know, before, during, and after? And we'll be returning to these concepts when we go over the results. I don't think I really need to, you know, elaborate on just how impactful the opioid crisis has been on BC, but I wanted to highlight just one figure here. So we're looking at 2 sets of data collected from BC CDC over the past 5 years. And in orange, we see the rates of illicit drug overdose deaths, and in blue, we have rates of paramedic-attended overdose events. And so just from the shape of the curves, you see that, unsurprisingly, there's a correlation. But when we look at the y-axes, we see that the rates of paramedic-attended overdose events are usually about 10 times higher than the rates of overdose deaths. And what this relates to is in 2019, we had over 12,000 paramedic-attended overdose events, which is staggering, and I think just quantitatively kind of demonstrates just how close paramedics are to these overdose crises and the overdose events themselves. I wanted to take a second to kind of talk about something that is kind of ironic to me, which is I'm about to give a presentation about paramedic experiences to a room full of paramedics who have more experience than I do. And on my end, it can feel like a little bit redundant to that extent. So I just wanted to say that, a success on my end would be, I think, that if you're able to see a bit of your own experience reflected in what we talk about, and also that we kind of have this presentation to be an opportunity to reflect on some of our own practice and some of our own experiences. And I think that we'll see that some of the themes we talk about can be kind of broadened to a lot of other aspects of our lives as well. So the methods are pretty standard for qualitative research. I started by recruiting 10 participants from Station 248. Sorry, we're having some delay here. Here we go. So 10 participants from Station 248, all of which were full-time paramedics. We then interviewed them. So we had individual face-to-face interviews for about 60 minutes with myself, followed by interviews over the phone, follow-up interviews for about 20 minutes with all the participants as well. We then transcribe the interviews. We go through this content analysis process with this program called NVivo, and we end up with a bunch of like a thematic framework. And then I then present that framework to a second researcher. So in this case, it was Gord Miniker. He's also a BC ambulance paramedic on the island. He's also a UBC medical student. And we just review the results together. We see that we just kind of talk about, are these results and interpretations reasonable? And then we come to a kind of consensus that way. And in total, we ended up with about 13 hours of interview content. And just to notice that, with an N equals 10, it's of course not going to be representative of this comprehensive paramedic population, but with 13 hours of content, I felt relatively confident that we were able to explore relatively in depth a lot of the topics that we wanted to discuss here. And so the results are divided into 4 themes, and each of the themes have 2 sub-themes attached to them. So we'll go over them one by one, but I'm going to spend a bit less time talking about the themes that I feel might be kind of intuitive or a bit unsurprising for a lot of the folks here, and spend a bit more time talking about the themes that I felt might be a bit more insightful. So this first theme is about shifting priorities throughout an overdose call. And it refers to essentially our cognitive framework that participants bring into overdose calls and to how they approach this type of response. And this first sub-theme has to do with paramedic safety and patient resuscitation as essentially the 2 golden principles. So the idea is that participants consistently upheld that paramedic safety, patient resuscitation were essentially the priorities, which I think is pretty unsurprising to hear that. But kind of interestingly, there seemed to be this cognitive distinction between pre-resuscitation and post-resuscitation. And the idea is that sometimes those 2 aspects, those 2 parts of the call can have different goals in mind for the paramedics. And so this post-resuscitation aspect has to do with transportation decision-making. So are we transporting? Where are we going? And essentially like that. And the idea is that participants express this kind of balance between paramedic and patient priorities. On the paramedic side, we're talking about clinical supervision. We're talking about gaining access to, I'll call them support structures, so things like opioid replacement programs or access to a social worker. And for those reasons, the hospital was consistently cited as the ideal place to transport. But as I'm sure we can guess, patients can have other ideas in mind, and they can have their own priorities, and they can be barriers to transporting to the hospital. So this idea of transportation decision-making emerged as this kind of complicated second half to the overdose call. As a short quote here, my job as I see it is that I've dealt with the medical and now it's the social. How can I advocate for you? You can accept it or not. So again, getting back to that idea of a cognitive distinction between pre- and post-resuscitation with different goals in mind. The second theme has to do with dramatic pause, normalization of overdose events in the context of an opioid crisis. So the key word here is normalization, and it's about what part of the overdose call has become normalized in the past few years, and then secondly, what impact has that normalization had on paramedics? And so the first part of that is that we're just seeing tons more overdose events in general. And so what that kind of led to is that participants were very confident in their clinical skills. And this is pretty universal. Participants felt very capable of doing their clinical assessment, and essentially resuscitating a patient. But the second sub-theme that emerged was pretty interesting. And this was not something that I went into the project hoping to bring up or expecting to bring up, but it was repeatedly brought up to me. And it's this idea of, I should mention here, for this quote, because like you said, we have the magic juice, we know what to do, we can bring these people back. The magic juice, we might be able to guess, is referring to naloxone. But anyways, these two aspects of the call that emerged as becoming normalized in the last few years was this idea of the experience of encountering patients repeatedly, so the same patient repeatedly, or patients refusing transport. And there's been a lot of studies and work put into why post-overdose patients might refuse transport to the hospital. And this study isn't really necessarily about the patient side of things. It's asking what impacts do these sort of encounters have on the paramedic. And there's a lot of interesting perspectives here. And I just wanted to read out a few quotes because I think that they kind of speak to the diversity of experiences on these two encounters here. So this first quote is, "At first it was heartbreaking. The first 20, 30 overdoses that you go to that are codexed by the patient, you feel a little disheartened afterwards. But now it becomes such a regular occurrence, there is not too much emotional attachment to it." So getting at the idea of this, just the emotional impact that consistently seeing patient transport refusal can have on us. I think it's so odd that we have such tolerance for repeat offenders, like people who have poorly managed diabetes, and somehow in the downtown east side we don't extend that same kind of tolerance. I think it's because of the stress it puts on us. I know for me, it's so overwhelming. When I go into these places, it's way more sad for one thing, and I'm so helpless to help. And then this last quote, "Knowing their name, or even them knowing you and being able to recognize you, it's such a huge leap forward in terms of being able to talk that person into going to the hospital. If they feel that you care about them or have that rapport with them, they're going to be way more open to listening to what you have to say." So this last quote is interesting to me because it speaks to this approach to repeat patients in which the response from the paramedic side is not frustration or anger, but seeing it as an opportunity to connect. And we're going to be returning to those two themes later on. The third theme was paramedic perceptions of drug use. So this is something that doesn't necessarily directly relate to the overdose call itself, but it's certainly related to that experience and can inform our experiences. So the first part of the question is essentially, what are paramedic perceptions of drug use? And this was pretty universal. Virtually all the participants recognize that substance use is rooted in personal trauma, and that there's framing it as essentially a coping mechanism as a result. But the second half is asking not just what are our attitudes, but how did these attitudes come about? How were they shaped? What led to having an understanding in the way that we do? And this was also pretty consistent, relating it back to these personal experiences. So more specifically talking about talking to patients, just being amongst the culture of the downtown east side and starting to kind of understand where their stories are coming from. This last theme is encountering and managing burnout. So burnout, of course, has this emotional component and like physical fatigue and emotional fatigue. And again, it's not something specifically related to overdose response, but it informs the type of mind frame that we're going into these calls with, and hence our experience during them. So there was two aspects that were commonly cited causes of burnout, physical fatigue at least. And these were high call rates, not having a lot of time between calls, as well as forced overtime. So this refers to being having 15 minutes left of the shift, you get a 90-minute call, et cetera, et cetera. So the first sub-theme here was this conflict between personal fatigue and responsibility as a paramedic. And it's this idea that we can oftentimes prioritize our professional responsibilities above what we feel like our personal needs are in that moment. Just waiting for a quote here. There have been days where I'm just going, I'm done today, I need to take it slow, but still I could be listening to the radio and thinking, it's so busy out there, my dispatcher is probably doing their best to deal with these calls, let's just clear and get going. So again, talking about that kind of push and pull between our responsibilities to not just the dispatcher, but I think more broadly just the medical system that we're in general, and our personal fatigue. And then to put it more concisely, because we don't want to be the one to say we're not going to that choking baby because we want to go pee. And then the second sub-theme to emerge from this one was essentially the flip side of that, which is how do we respond and promote resilience amongst ourselves. And of course, there's going to be a range of responses here, a range of tactics. A lot of them that we saw boil down to this idea of communication, so talking with colleagues, peers, professional supports, counselors, family members, et cetera. And just to end it on kind of one particular quote here, and we do see a lot of tragedy and a lot of sadness and a lot of hurt down there. We also see a lot of really funny people. I know it sounds corny, but for me, it is focusing on the fun aspects of the day. So again, just one of many different forms of resilience. Now, the next part, the last part of the results, and what I actually wanted to spend a bit more time focusing on was this concept called the basic social process. And essentially, after we had identified and described the themes that we just went over, we then asked ourselves, can we put all of these results into a larger framework and try to understand really the underlying concepts of overdose response? And what we came up with was this idea of navigating our personal influence in the context of a very complex situation. So what does that mean? It's essentially suggesting that an overdose event is an acute event, but that the experience of overdose response actually asks paramedics to engage with a very complex chronic health condition, and recognizing, so that being chronic substance use, and understanding that that condition is oftentimes complicated by a lot of the social determinants of health, like housing instability, as well as other medical comorbidities. And it's this idea that when we're encountering such a complex situation, we can feel like we don't have a capacity to provide meaningful care to our patients. And that feeling of disempowerment as kind of informing and leading some of the negative experiences that we might have during something like overdose response. And so we identified 3 components that can influence our perception of personal influence. And the first has to do with this idea of immediate care. So immediate care is essentially clinical resuscitation. And it's impacted by things like our physical environment or the presence or absence of bystanders, our amount of experience that we have as paramedics. And then the second aspect has to do with longitudinal care. And longitudinal care is when we're trying to address the underlying causes of substance use. So again, going back to that idea of the social determinants of health, or trying to get access to an opioid replacement program. And this is impacted by things like accessibility. Are these programs accessible to us? As well as the patient perspective. Are patients consenting and interested in even accessing these programs in the first place? And so these 2 ideas are kind of external factors, right? And external factors like the presence of bystanders. But we also have, as this final component, these personal factors. And these are essentially the attitudes, our approaches, and expectations that we bring in to an overdose call. And it's this idea that our attitudes can impact our experience, and our experience can impact our attitudes. So when we have a framework like this, it allows us to go back and recontextualize and revisit some of the themes that we brought up earlier. So for example, we talked about this idea of encountering repeat patients or patients that refuse transport. And we recognize that sometimes these are experiences that can lead to frustration or anger. And the framework kind of suggests that these two experiences are difficult because they can potentially challenge our perception of our capacity to provide meaningful longitudinal care. And it's this idea that when we see the same patient repeatedly, that can imply that maybe our care that we provide is insufficient or it's inadequate. And when we have patients that refuse transport, they can feel like our capacity to provide longitudinal care is diminished. And I think it's relevant to talk about this concept of what I call the paramedic toolkit, which is essentially that as paramedics, a lot of the training and a lot of the tools in our box are related to providing immediate care. And that's important because obviously we want to feel competent and prepared when our personal actions can really impact patient outcomes. But at the same time, we also have this drive and this desire to address longitudinal care. And this is a natural response. When we can identify the barriers to patient health, we want to be able to address them. But the idea is that there aren't protocols really for addressing longitudinal care or facilitating longitudinal care. And the pathways to making that happen can be context dependent, and they can be a bit more enigmatic. And the idea is that overdose response as a concept can really emphasize the difference between our tools for addressing immediate care and our tools for facilitating longitudinal care. And it's just that discrepancy, again, that can be difficult. On the flip side, though, this framework kind of suggests ways to address this idea of disempowerment. So, for example, programs or I'm thinking of something like post-overdose supervision sites that popped up within the downtown east side. So paramedics could take patients there. Oftentimes in the community, they're run by peers. Patients might be more open to going to them. And so essentially these initiatives that empower patients will also, in effect, also empower paramedics at the same time. And I think it's kind of good timing that we actually discuss the idea of palliative care. Because I think when we think back to the palliative care initiative that we just heard about, it actually touches on a lot of these concepts. It's an initiative that I interpret it as, it's rooted in patient comfort, right, and a patient experience. But at the same time, we can imagine that the experience of encountering a palliative patient can oftentimes leave us feeling like the care we provided is not enough. Maybe transport to the hospital wasn't the best decision. I feel like it wasn't the best decision, but it's all that maybe I had as an option. So when we start introducing options for paramedics that allow them to address these situations, it's good for the patient, it's good for the paramedic as well. And then the last bit is this entire idea of the personal factors as well. So just thinking back to that quote about the participant that saw repeat patients as an opportunity to connect. And I think it's worth kind of taking the time to ask ourselves how we can facilitate or try to bring out and latch onto these sort of attitudes and these sort of approaches to the care that we provide. Are there attitudes that we can bring forth into a call that can take what can potentially be a challenging situation, external situation, a patient that refuses transport or that is being seen chronically, and our interpretation of that becomes a positive one? And then, going further with that idea, I think it's kind of interesting to think about how we can try to foster those attitudes systemically. So in other words, are there ways, can we imagine a way of training paramedics such that they feel confident and competent to provide immediate care, but at the same time feel empowered and feel like they have toolkits to address and facilitate longitudinal care? So I just kind of wanted to conclude and wrap up this presentation with one last kind of a comment. And because I feel like we started this conversation talking about a pretty specific experience, which is overdose response in the downtown east side. And we kind of ended up talking about kind of abstract concepts, like this idea of disempowerment, this idea of our personal influence, et cetera, et cetera. But I think we can appreciate and understand that overdose response is not the only way to get into this conversation about disempowerment. In other words, that there are a lot of other situations that can kind of fit more broadly into the concepts that we were discussing. And so this is what I kind of mean by, hoping that the presentation today kind of leads us to reflect on our own practices, our own experiences in ways that might be related directly to overdose response, but then potentially we can apply to other situations as well. I'm just waiting for the kind of conclusion slide to pop up here, but essentially I have a lot of people to thank. I have an amazing team of supervisors, Anita Palliative, Ann Gaterman, Gordon Miniker, and Jane Buxton, and also wanting to take a moment to thank all the study participants as well as all of the paramedics that are currently working and have been involved and will continue to be involved in this ongoing opioid crisis. And that wraps up my presentation. Again, thank you for allowing me to speak, and there's the floor.
Thanks very much, Jordan. Congratulations on a fascinating and I think very important piece of work. Couple of questions. First one being just a quick definition question. How did you define overdose? Like of the 12,000 overdose events, understanding probably the majority are opiate, and there is polypharmacy. Were they opioid-specific overdoses, or was it all-coming overdoses?
Yeah, those were directly, so the slide we're talking about, all directly came from the BCEHS, from the overdose response indicators. So my understanding of them is that they were included opioid and, of course, everything else. Paramedic attended overdose events.
Gotcha.
Broadly.
And then a second question is the participants that you had, were they both PCP and ACP, or was there any difference in their, if they were ACP and PCP, and if it was all PCP, question I guess for the group at large and or yourself is, do you think there'd be any difference in results between PCP and ACP paramedics?
Mm-hmm. So they were all PCP paramedics. It's tough to say whether there would be differences in results. We had an equal gender representation. There was quite a wide range of seniority differences, though. And one thing that I did find, I didn't report on it because I wasn't super comfortable enough with it, but it seemed like the more experienced paramedics that had been in the service longer felt a bit safer, in their sense of security around within the downtown east side. So maybe small things like that could be different, but I think talking more broadly about the kind of the broad conclusions of what we see in like the basic social process, I think that those kind of dynamics should be pretty universal. With that being said, the ACP experience is going to be very different from the PCP experience, specifically related to overdose response. But again, making it more broadly, that idea of disempowerment, I'm sure it can also be related to another context as well.
I think the cohort of people that you did interview probably give you a lot more valuable insight into that longitudinal care side of things, because from the ACP side, we're often involved in that initial resuscitation, but as soon as that patient is returned to a safer place from a resuscitation point of view, we're often then removed from that call.
Yeah.
So probably less value in sort of that longitudinal side of things.
Yeah, just to repeat the comment was that PCPs are a great cohort for the longitudinal aspect, where ACPs are mostly involved in the resus and often not after that. So from an ACP perspective.
Jordan, did you find any other literature done prior that supported this idea of disempowerment paramedics?
Yeah, so the question was about like previous literature that already exists about this idea of disempowerment. So I started with looking at, so in terms of the previous literature, one aspect is like, has other studies asked similar questions, right? And the one other thing I did find is that there have been studies that have asked about the experience of the overdose crisis as healthcare workers, but they involved a lot of other different, like a very wide group of healthcare practitioners, like nurses, ER physicians, fire, ambulance, police. And so in terms of like the literature, I think this study is unique in that it specifically focuses on paramedics. For the idea of disempowerment, yes, but it crops up in other contexts too. So, there's not really, I couldn't find anything directly related to the paramedic experience, but it pops up in things like, or specifically related to overdose response, but it comes up in, for example, a paper about self-harm, providing care to folks who self-harm. And so like that idea is popping up in other contexts, but not specifically overdose response yet.
Yeah, it seems to me you've done some actually groundbreaking research from a paramedic sort of methodology perspective, where you're applying a theory to a group that has not had very many theories applied to why things happen the way they do.
Yeah.
So I would suggest this is incredibly groundbreaking and will really be helpful in applying theory to future practice initiatives, to education, to approaches to care.
Yeah, thank you.
Have you got plans to publish?
Yes, hoping to submit maybe this weekend, maybe the next weekend, but we'll see where it goes with that.
Yeah. And just one other comment, so summary so far, the comments in Vancouver have been this is groundbreaking research and plans to publish. Just as part of the sort of last cloud slide and the higher, the concepts that you take from this, one thing that I think that is an important BCEHS goal that I think would apply to this patient population and many others is the concept of giving feedback to paramedics about patient outcomes. So for example, if you see someone refuse to go to a hospital for an overdose 3 times, but yet you were to learn later down the road they actually did get connected with help and you were maybe part of that process, I think that would be an important tool to maybe empower and feel that your skills and communication, you are actually making a difference and well equipped on some of these calls. So I think just as a medical director, and again, you guys always say you want more feedback on how patients are doing, and I think this would yet be another example of how that would possibly be helpful. Yeah, that's something I just kind of thought of for the last slide. So
yeah, it popped up in the study a few times for sure. Yeah.
Okay. Any other questions at all before we wrap it up? Or all right. Well, thanks everyone again for attending. We will see you all back in March. A huge thank you to all of our presenters today. Great job, and yeah, we'll see you in March. Thanks for attending.